Welcome to the Deep Dive, your shortcut to being well informed, especially when the stakes are sky high. Today, we're diving headfirst into a truly critical, high-pressure area of emergency medicine. Picture this. You're in the ED, patient rolls in, monitor goes off, rapid, wide QRS. Your own pulse quickens, right? You're thinking, what is this rhythm? VT, SVT. How fast do I need to move? Today, we're cutting through that noise. We're drilling down into broad, complex tachycardias, specifically ventricular tachycardia, those really challenging, undifferentiated cases, and the ever-present specter of VFib, our mission, to arm you with the clearest, most actionable insights from the latest thinking, giving you that confidence for life-saving decisions.
Yeah, it's exactly that kind of scenario where clear, immediate thinking is just paramount. And today we'll hopefully demystify these arrhythmias a bit, connect those ECG patterns directly to what you need to do right now.
Okay, let's unpack this then. When we talk about a broad complex tachycardia, or BCT, what does that actually mean on the ECG? What's it telling us?
Fundamentally, it's a QRS duration of 0.12 seconds or more. That whiff tells you the impulse isn't taking the normal superhighway through the conduction system. It's either starting at the ventricles or it's getting conducted aberrantly, taking a detour through the ventricular muscle itself, which is slower.
Right. And here's the crucial part for the ED, the real take-home point. What's the default assumption we have to make with these rhythms, especially when the clock is ticking?
This is probably the single most important principle. The overwhelming majority of broad, complex tachycardias are ventricular in origin, period. So any regular, broad, complex tachycardia, you must assume it's ventricular tachycardia VT until proven otherwise. Full stop.
Until proven otherwise.
Exactly. And this isn't just being cautious. It's statistically sound. The assumption gets even stronger if the patient's, say, over 35 or has any history of heart disease, ischemic structural, previous MI. If there's any doubt in your mind, you treat it as VT. It's protective to the do-no-harm approach here.
So, for you listening, when that patient hits your bay with a BCT, the first thought firing should be, this is VT. That initial mindset is absolutely key.
Okay, so given that VT is our default, let's dig into it. What does VT actually look like? Let's start with monomorphic VT. What are the telltale signs?
Okay, monomorphic VT. Think 3 or more consecutive ventricular beats, fast rate over 120, usually up to maybe 250 beats per minute. And crucially, it's typically regular. The mono part means each QRS complex looks the same beat after beat. But, and this is important, that morphology is different from the patient's normal sinus rhythm QRS.
Wider, presumably.
Oh yeah, much wider, usually over 0.12 seconds, like we said for BCTs. But if you see a QRS wider than 0.16 seconds, that is highly suggestive of VT, really points away from just aberrancy. Often you'll see patterns like a right bundle branch block morphology, which might suggest the VT focus is actually in the left ventricle.
Gotcha. Are there any other specific ECG clues, those sort of VT giveaways? Definitely. There are a few classic signs to look for, though you don't always see them all. First, a bizarre axis. If lead AVR is predominantly positive, pointing upwards, that's a big red flag. The old mnemonic, up in AVR, the axis is bizarre. Then there's AV dissociation. This is where the atria and ventricles are beating independently. You might see P waves marching along at their own rate, completely unrelated to the wide QRS complexes.
Hard to spot sometimes, though.
Can be very hard. P waves often get buried in the wide QRS or T waves. But if you do see it, it's almost diagnostic of VT. Related to that are capture beats suddenly. A normal narrow QRS pops up amidst the VT. That's the sinus node momentarily capturing the ventricle. And fusion beats, which are like a hybrid QRS, a mix of a sinus beat and a VT beat colliding.
Okay. Capture and fusion. What else?
The last big one is concordance. This is when all the QRS complexes across the chest leads V1 through V6 are either all positive or all negative. That points strongly towards VT.
Wow, okay. That gives a pretty clear picture for monomorphic VT. But what about the more chaotic-looking ones?
Right. Then you've got polymorphic VT. As the name suggests, the QRS complexes vary in shape, amplitude, and duration from beat to beat. It looks much more disorganized. It's less common, usually not sustained for long periods, but it's often a very dangerous sign, frequently a precursor to ventricular fibrillation, VF.
And within polymorphic VT, there's torsades, right?
Exactly. Torsades de Pointes, twisting of the points. It's a very specific type of polymorphic VT. You see this gradual oscillation in the QRS amplitude, so it looks like it's twisting around the baseline. The absolute key association here is a prolonged QT interval on the patient's baseline ECG, whether that's congenital or more commonly acquired, often due to medications or electrolyte issues. Torsades tends to recur and can degenerate into VF very quickly.
Any other VT forms that might try to trick us in the ED?
Yeah, a couple worth mentioning briefly. Vesicular tachycardia is one. It originates down the fascicles of the left bundle branch. The tricky part, the QRS can be relatively narrow, maybe 0.11 to 0.14 seconds, so it might not look broad enough initially, leading you down the SVT path. Usually has an RBBB pattern with left axis deviation.
Ah, okay. A potential pitfall.
Definitely. And then there's right ventricular outflow tract tachycardia, or RVOT-VT. This typically has an LBBB morphology with a rightward axis. Less common, but good to be aware of.
Okay, so we've established the assume VT rule, but how do we spot those exceptions? When should we start thinking, maybe this is an SVT with aberrancy? What clues nudge us that way?
That's a great question because while the rule is vital, you do need to keep an open mind. Certain features might suggest SVT with aberrant conduction, maybe a pre-existing bundle branch block, or something like Wolff-Parkinson-White syndrome. Clues could be a younger patient, say under 35. Sometimes the rate, if it's right around to 150, or paradoxically super fast, like over 200, but the patient looks surprisingly well. Also, if the QRS is wide, but just barely, like less than 0.14 seconds, if the axis is normal, and importantly, if you don't see those VT-specific features we talked about, like AV dissociation or concordance.
Okay. Are there specific SVT scenarios that commonly present as wide complex?
Yes, a couple are really important. The most common cause of an irregular, sustained, broad complex tachycardia is actually atrial fibrillation with a pre-existing bundle branch block. Polymorphic VT is irregular too, but usually not sustained like AF can be.
Ah, okay. AF with BBB. That makes sense.
But the really critical one to identify is pre-excited atrial fibrillation. This is AF happening in someone with an accessory pathway, like in WPW syndrome. Here, the impulses bypass the AV node and flood the ventricles via that fast accessory pathway. You get incredibly rapid rates, sometimes over 200, even 300 BPM. The ECG shows an irregular wide QRS rhythm, often with visible delta waves if you look closely.
And this is the one with the major treatment pitfall, right? The absolute no-no.
Exactly. This is life-saving knowledge. For any patient with suspected pre-excited AF, it's like WPW with AF, all AV nodal blocking drugs are absolutely contraindicated. I can't stress that enough.
So no adenosine, no beta blockers.
No adenosine, no beta blockers, no calcium channel blockers like verapamil or diltiazem, no digoxin, and actually no amiodarone either in this acute setting.
Why is that so dangerous?
Because if you block the normal AV node pathway, you essentially force all the atrial impulses down that fast accessory pathway. The ventricular rate can accelerate dramatically, potentially leading directly to VF and sudden death. We should also briefly mention antidromic AV reentry tachycardia, another WPW thing. Conduction goes down the accessory pathway and back up the AV node. It results in a regular, wide, complex tachycardia that can look identical to VT.
Man, lots of nuances there. Okay, we've mentioned polymorphic VT leading to VF several times. Can we just solidify that connection and where VFib fits in?
Absolutely. Polymorphic VT, especially torsades, is inherently unstable. It frequently degenerates directly into ventricular fibrillation, which is just chaotic, uncoordinated electrical activity. VF means no effective cardiac output. It is cardiac arrest. The only treatment is immediate defibrillation.
And the WPW connection.
As we just discussed, in WPW with AF, that incredibly rapid ventricular response over the accessory pathway can itself trigger VF. It's a direct link between a supraventricular arrhythmia and sudden cardiac death in those patients.
We also touched on Brugada syndrome earlier. How does that fit with VF?
Brugada syndrome is an inherited channelopathy, a problem with ion channels in the heart muscle. It causes characteristic ECG changes that coved ST elevation in the right precordial leads, V1 to V3. Patients with Brugada have a significantly higher risk of sudden cardiac death, specifically due to polymorphic VT or VF, often occurring at rest or during sleep. It's another underlying condition predisposing to VF.
Which leads us to things like ICDs, implantable cardioverter defibrillators. They're designed precisely for this risk, aren't they?
Exactly. ICDs are the main therapy for preventing sudden death in high-risk patients, including those who survived a VF arrest, or those with conditions like Brugada or certain cardiomyopathies. They monitor the heart rhythm constantly. If they detect VF or sustained fast VT that doesn't respond to pacing, they deliver an internal shock to restore a normal rhythm.
Do they do anything besides shock?
Yes, many modern ICDs also have anti-tachycardia pacing, or ATP. If they detect VT, they can first try to deliver rapid pacing pulses to try and overdrive the VT and terminate it without a shock. It works surprisingly often, over 95% of the time, for many VTs, which is much better for the patient than getting shocked.
Okay, super important context. Now let's get to the sharp end, management in the ED. You're faced with a wide, complex tachycardia. What dictates your first move?
One thing above all else, is the patient stable or unstable? That's the absolute first branch point.
And define unstable for us in this context. What are the hard signs?
Unstable means the tachycardia is causing signs of significant end-organ hypoperfusion. So we're looking for shock systolic below 90, cool clammy skin confusion, syncope or significantly decreased level of consciousness, signs of myocardial ischemia like acute chest pain or ischemic ECG changes, or acute heart failure, think pulmonary edema, maybe a really elevated JVP.
Okay, so if any of those are present and you think it's due to the tachycardia,
Then it's simple. Immediate synchronized DC cardioversion. Don't delay, don't waste time trying drugs first.
what energy level?
For a broad complex tachycardia, generally start at 120 to 150 joules using a biphasic defibrillator. If it's likely AF, you might even start higher, sometimes at the maximum output. If the first shock doesn't work, increase the energy for subsequent attempts. You can try up to 3 shocks in rapid succession if needed.
And if 3 shocks fail?
If 3 shocks fail and the patient is still unstable, then you consider an antiarrhythmic. The standard recommendation is amiodarone, 300 milligrams IV over 10 to 20 minutes. Then you'd attempt cardioversion again.
So instability equals electricity, basically.
Exactly. Unstable patient needs electricity, not drugs, regardless of the rhythm underneath. Get the perfusion back first.
Okay, clear. Now, what about the stable patient? They have a BCT, you're assuming VT, but their blood pressure is okay, they're alert. What then?
Right, stable VT gives you a bit more breathing room. The traditional first-line drug has been intravenous amiodarone, that 300 milligram dose, but may be given over a longer period like 10 to 60 minutes. However, and this is a really interesting point from recent evidence, amiodarone's actual success rate for acutely terminating stable VT might be lower than we thought, perhaps only 15 to 30% in some studies.
Really? That low?
Yeah, it's making people reevaluate. Drugs like intravenous procainamide, maybe sotalol, are often more effective. Procainamide in particular has shown better results than amiodarone in some head-to-head trials for stable monomorphic VT, with potentially fewer side effects too.
So procainamide might be a better first choice now.
It's definitely a strong contender, yes. Also, don't forget, synchronized cardioversion is still a perfectly valid and often faster first-line option, even for stable VT. And critically, always check and correct electrolytes. Low potassium or magnesium can perpetuate VT.
Got it. What about stable polymorphic VT, specifically Torsades?
Torsades management is different. If they're stable, the absolute first steps are stop any potentially QT prolonging drugs they're on and give intravenous magnesium sulfate, typically 2 grams over 10 minutes, even if their serum magnesium level is normal. Correct other electrolytes like potassium too. And you should definitely be seeking expert cardiology help at this point. If they become unstable at any point, though, it's immediate cardioversion.
Okay. And finally, let's circle back to that dangerous one. Stable patient, but you suspect pre-excited AF, the WPW with AF scenario.
Right. Remembering those absolute contraindications for AV nodal blockers. If the patient is stable with suspected pre-excited AF, the go-to drugs are different. Intravenous procainamide is a good choice here. Intravenous abutylide is another option mentioned. Sometimes intravenous flecainide is used too. The key is using drugs that don't primarily block the AV node.
This has been a really comprehensive deep dive. It really highlights how critical understanding broad, complex tachycardias is in the ED. That default assumption, regular BCT is VT until proven otherwise, is huge. But also knowing those nuances, the mimics like SVT with aberrancy, the specific dangers of pre-excited AF, the link to VF, it's complex, but absolutely vital.
Absolutely. And the goal isn't just memorizing algorithms, it's understanding the why behind them. Recognizing instability instantly, knowing when electricity is non-negotiable, and choosing the right approach for stable patients based on the likely rhythm. That's critical thinking in action.
So for everyone listening, the next time that wide, complex tachycardia rolls into your bay, pause for just a second. Run through these points. Does the history, the ECG, scream VT, are they stable or unstable? And are you ready to act decisively with drugs or, more often than not when things get serious, with electricity? Thank you for joining us for this deep dive. We hope distilling this gives you more confidence when facing these challenging rhythms. Reflect on these principles, they can make all the difference.